Thank you, Pascal. It's a pleasure to talk to all you guys this morning. Sometimes people complain about the cost of medicine and how costly the U.S. healthcare system is and how we're sort of behind the world. But I've got a slide up here to just sort of show you what value cardiovascular medicine has brought to the United States. You can see the yellow line is basically the life expectancy, the average number of deaths occurred of cardiovascular disease in 1973. And you can see that the peak actually started in young adults, basically, and sort of then peaked in middle age. But over the last 25 years, that has actually shifted over to the left by about 10 years. As all of you know, the life expectancy in the United States between 1973 and 2000 increased by about 10 years in America. And let me put that in perspective for you. At the time of the birth of Christ, the life expectancy of people was 33 years. In 1900, the life expectancy was 55 years. So over a 2,000-year period, the life expectancy went up by 20 years. In a 25-year period, the life expectancy went up by 10 years. So just absolutely extraordinarily increase in life expectancy, in particularly the United States. So if you ask, has there been value for all this, I would say unequivocally that we've extended life by 10 years. So that has a variety of consequences. And so now what you're seeing is people presenting for heart disease about a decade older than they did back in 1975. And whereas it was very rare to treat, I mean, I can recall as a cardiology fellow in the early 70s, it was really rare to take a patient to the cath lab at age 70 and older. I mean, they just weren't around. First of all, they'd already died. And second of all, there wasn't much that we could do. But now, routinely we're taking these patients at 85, and yesterday we did a percutaneous valve implant on a 95-year-old patient. So and that obviously is going to have societal consequences, but for you folks, it's going to have a lot of enormous financial and business consequences. So what we're going to be dealing with is we're going to have to find therapies for people in their 80s and 90s, because the fastest growing subgroup of people in the United States now are women over the age of 80. That's the fastest growing population subgroup. And so we as healthcare providers are going to have to find new therapies for older people. The epidemic of cardiovascular disease peaked probably about 1985. And what we've actually seen is, I think, a recrudescence and an amelioration of cardiovascular disease as a form of morbidity and mortality. And you can just see that by the numbers of cardiac bypass surgeries that have occurred. The numbers dramatically went up between 75 and 2000. Between 2001 and now, over the last decade, the actual numbers of open heart surgeries continue to decline. The number of angioplasties is also stabilized and is slightly declining. And so I think that epidemic really is now dramatically changed. I want to share another anecdote with you. In 1952 to 55, the field of thoracic surgery almost died. There was nobody that was doing thoracic surgery. And why is that? Well, at that time, thoracic surgery was related to pneumonectomies, to pleurodesis, to scarring, all related to one disease called tuberculosis. So the thoracic surgeons all were living on this one particular disease. Well, in 1955, INH came out. Tuberculosis is cured and that field dies. And it's very possible that we're getting close to that with coronary artery disease, with aggressive risk factor modification, very aggressive statin therapy. We may actually be ameliorating or actually causing a decline in cardiovascular disease. And so it's going to be really fascinating to see the consequences as the boomers start getting into this age group where they're at risk for cardiovascular disease, but they're living a very healthy life, much more active, much more health conscious, many fewer smokers, and much more use of statin therapy. So those consequences, I think, on a society basis are going to have to be taken into account. Well, I'm going to just briefly, I'll tell you some of the areas of expertise that the panel have, and then obviously you can have a Q&A for the remainder of this time. I've been involved with the percutaneous aortic valve, the Edwards Sapien valve. I put the first implant here in North America in 2003. We have a very active program here, and we've treated over 150 patients in the protocol. My colleague, Dr. DiMarcena, is actively involved with the core valve. He's actually implanted more core valves than any other U.S. operator and has been working in Colombia now for almost 3 years with his implants. So on this panel, you have the unique opportunity to talk to investigators that actually have a great deal of hands-on experience with both of these devices. So for America, that's incredibly odd because we've been primarily using Edwards with very little core valve experience. So I think it'll be kind of interesting for you to discuss. The other area that Dr. DiMarchena has been working on is he's head of our international medicine program, and we've actually been designing a program to start doing trials, and we're actually taking U.S. patients. Dr. DiMarchena is taking a number of U.S. patients to Cali, Colombia, to implant the core valve, because unfortunately at this point we've become a third world as far as new device evolution. Europe and South America and Asia have much quicker access to these medical devices, and we're trying to figure out what the consequences are going to be to patients and also to the healthcare industry. Offshoring of new devices and offshoring of new clinical protocols is going to be an enormous fact that we're all going to have to address, and we have to understand what the consequences of that will be. Dave So is here. He's actually a world's expert on cell therapy for atherosclerosis, and he will be able to discuss with you the brand new approaches. And basically, I think Dave will be able to tell you the concept of arterial injury and repair, the fact that stem cells and progenitor cells are the main repair organ, and one of the, obviously the largest organ in the body by square surface area is the endothelium, and to be able to repair that area with cells and the consequences of inability to repair those cells have huge implications for atherosclerosis and other disease processes, and he'll be here to share his expertise in that area. These are Dr. Hare's slides, and they're just absolute, and that's fine right there, we can just leave those on. Okay. So you can see what Josh is trying to show you is this is an area of infarcted myocardium in a patient that's had an extensive anterior wall infarct, and this is the patient treated a few weeks later with stem cell injection. He and Dr. Alan Heldman are actually taking a catheter and with needles putting in stem cells in this area of infarcted myocardium, and you can see how much more robust the thickening is in this particular portion of the heart. It's been very difficult to demonstrate proof of efficacy of stem cell infusion and stem cell injection, but with these very, very sophisticated imaging techniques, they are going to be able to demonstrate that there's actually a consistency. We have enormous excitement here in Miami about stem cell therapy for repair of damaged myocardium, not only in patients with coronary disease, but also with non-ischemic cardiomyopathy. And in fact, we are, I think, truly one of the world's leaders in this specific form of therapy. So the consequences of this, obviously, we'll be very happy to discuss with you. But Josh is really, truly a pioneer and a leader, and he's got an enormous amount of information to add to this. And then, are there slides from Dr. DiMarchena?
No, I don't think so.
No, okay, so basically, then I just want to tell you what other areas we'd be happy to discuss. We've all been involved with many pharmacologic trials. I led the international study using a glycoprotein receptor antagonist. We have been involved with acute infarct trials, whatever cardiovascular pharmacological trials you want to talk about. In addition, Dr. Hare has been directing our heart failure program, so he's thoroughly, proficient and can able to discuss any questions you have about heart failure, left ventricular assist devices, support devices, and all of that. I was an international PI for the PROTECT-2 study, which is a study of the Impella device from Abumed, and if any of you have an interest, we can happy to talk about that. And Dave So is actually an incredible genomics expert, so any questions about the future of genomics and how that's going to roll out in cardiovascular disease, we're happy to discuss. So, Pascal?